This presentation is on hypertension in the American Indian population for NUR 810. All members of our group have abided by the UNCG Academic Integrity Policy.
The United States has often been described as a melting pot nation, comprised of our native peoples and immigrants from all over the world, whose rich history is woven into the fabric of our country's culture. There are 574 Native American Indian tribes that are legally recognized by the United States Bureau of Indian Affairs. According to the 2020 U.S. Census, the tribe with the largest population is Navajo at 14.6%, followed by the Cherokee at 10%, the Choctaw at 3.2%, and the Lumbee tribe of North Carolina at 2.5%. Within North Carolina, there are 8 state-recognized tribes, including the Eastern Band of the Cherokee, Siouan, Saponi, Occaneechi, Meherrin, and the Lumbee. We have decided to focus our presentation on the Lumbee tribe of North Carolina. With more than 70,000 enrolled members, the Lumbee tribe is the largest tribe in North Carolina and the largest Native American Indian tribe east of the Mississippi River. The Lumbee tribe has a long and storied past. They have sought recognition from the federal government since 1888. The tribal name changed 4 times alone from 1885 to 1956, from the Croatans to the Cherokee Indians of Robeson County, to the Siouan Indians of the Lumber River, and finally, in 1956, Congress recognized the tribe as the Lumbee Indians. The tribe was ultimately named for the Lumbee River, an ancient river that flows through Robeson County, North Carolina. Differ from many other Native American Indian tribes in that they were never placed or relegated to reservations, largely in part to their long struggle for federal recognition. The vast majority of Lumbee Indians live in Robeson County. It is a rural, impoverished county located in the coastal plains of southeastern North Carolina. The county has a population of 116,000, and of that population, 46,281, or 39.6%, are Lumbee Native Americans. According to 2010 census data, the median family income for a household in Robeson County was $32,514, with 31.1% living below the poverty level. In the United States, Native American Indians have higher rates than Caucasian Americans for common chronic diseases such as diabetes, stroke, heart disease, obesity, mental health disorders, and hypertension. Research has determined that these higher rates are related to social determinants of health, such as poverty, limited access to health care, and systemic racism. The 1956 Congressional Lumbee Act officially recognized Lumbees as an Indian tribe, but the Lumbees never received full recognition and thus are ineligible for federal Indian health service benefits. This limits their access to health care options. The Lumbees of Robeson County can often obtain health services from one solitary federally funded community health center. Many also use private physicians if they are fortunate enough to have health insurance. Living in a rural community also limits economic and educational opportunities for the Lumbee Indians. Many parts of Robeson County could be considered food deserts due to not having a grocery store in close distance. There are often low rates of medication adherence in this population, stemming from a historical mistrust of healthcare providers and economic challenges that limit the ability to purchase costly medications. Native American Indians, including the Lumbee, have beliefs and cultural practices that are often not commonly practiced or in alignment with the practices of Western medicine. Many Native Americans believe that the connection between the individual, the community, and the natural world is central to a person's health. They believe in holistic traditions in health, such as using plants and food for their healing properties. They may participate in sacred healing ceremonies. Many Native Americans believe that good health involves living in harmony with the environment and having a close connection to the earth. These cultural values, beliefs, and practices pose another challenge to healthcare provision in this population. It is important that providers are aware of these cultural belief systems and practices.
So hypertension is a major health problem affecting the American Indian population. So hypertension and cardiovascular disease are going to disproportionately affect the American Indian population compared to other groups such as white Americans within the United States. Hypertension is prevalent across many ethnic groups, but American Indians are going to face a combination of physiological, lifestyle, and socioeconomic factors that are going to increase their risk of developing this condition. So these factors are going to highlight the need for healthcare providers to deliver culturally appropriate and community-centered care to address hypertension within this population. And by addressing hypertension in the American Indian population, we're hoping to decrease the prevalence of this disease and increase the health of the population. Implications for clinical practice are going to include access to healthcare, quality of healthcare, and cost effectiveness of potential solutions. So, access to healthcare is important because limited access to healthcare is going to remain a significant barrier to the prevention and management of hypertension among American Indians. And there are several factors that are going to contribute to this disparity, and those include geographic isolation, transportation challenges, and financial barriers. Quality of healthcare is another important clinical implication, as quality of healthcare in the American Indian population is significantly lower than that of other populations in the United States. A major contributing factor to this is going to be historical trauma. Historical trauma fosters distrust towards healthcare institutions, creating barriers to communication and trust between patients and providers. This mistrust can negatively influence treatment adherence and overall quality of care. Cost effectiveness of potential solutions is super important. So when addressing hypertension in the American Indian population, it's going to require integrating evidence-based practice with community-centered care. These approaches can be cost-effective by promoting prevention, early detection, and long-term management, which is going to reduce the overall burden of chronic disease and healthcare cost. So potential solutions that are cost-effective include community needs assessments, health fairs, talking circles, in-school education, and the use of tribal health ambassadors. So a community health needs assessment is an effective yet time-consuming tool that could help determine the comprehensive health needs of the tribe. A health fair is going to address things such as diet, lifestyle choices, mistrust, and resource barriers that affect the prevalence of hypertension in this population. Talking circles are culturally rooted gatherings that encourage open communication and collective problem solving. So talking circles can be used to help discuss health concerns and then share experiences and strengthen trust between healthcare providers and community members by sharing their insight. In-school education can promote early awareness of hypertension prevention, healthy nutrition, and physical activity in school-aged individuals. And then lastly, tribal health ambassadors are essential in addressing hypertension among American Indians. They're going to help implement culturally tailored education. And it's going to promote trust, awareness, and effective disease management. Given the expansive time and resources needed to conduct a community health needs assessment and the approval required to provide in-school education, we have decided to conduct a health fair focusing on blood pressure monitoring and education by trusted resources. So, our intervention is guided by Pender's health promotion model, which emphasizes the role of individual characteristics and experiences, behavior-specific cognitions and effect, and behavioral outcomes in shaping health behaviors. So this model is going to highlight how personal, cognitive, and environmental factors interact to influence an individual's motivation to engage in these health-promoting actions. We chose to implement our intervention based on this model because it focuses on health promotion rather than disease prevention, which is going to empower American Indians to take control of their health and make positive lifestyle changes before hypertension develops. This approach will enhance perceived self-efficacy, encourage healthy behaviors, and ultimately improve health outcomes within this population. So, when planning our health fair, we decided that we would include a variety of booths, each offering a specific service or educational opportunity related to hypertension prevention or management. While a health fair is an effective way to address hypertension in the American Indian population, it is essential that we tailor the information and education provided to ensure cultural sensitivity and maximize the effectiveness of the intervention. So to promote cultural relevance, we plan to partner with trusted community members, including local chefs, American Indian nurses, and medical providers, to deliver services and education during the event. So we have decided that there will be 2 booths designated for blood pressure screenings. Here, we will have nurses that will take manual blood pressures and provide immediate feedback. And then after these results are collected, we will refer individuals to one of 4 private consultation booths where healthcare providers can discuss findings, answer questions, and recommend personalized interventions. This structure ensures privacy, fosters trust, and allows for individualized education and care tailored to each participant's unique needs and circumstances. So following this screening, participants can visit a booth led by a local chef who will provide examples of and education surrounding culturally appropriate, heart-healthy food. This activity promotes practical nutrition education and empowers community members to prepare traditional American Indian dishes that support cardiovascular health. And because diet is a significant cause of hypertension in this population, this is such an important intervention. And we will also have talking circles available. And these talking circles are going to be so important because they are traditional and respected practices within many American Indian communities. So they're going to provide a safe space for open discussion and mutual understanding. This setting encourages participants to share about their experiences, express their thoughts about hypertension, and listen to others' perspectives in a non-judgmental and culturally affirming environment. So together, we think that these interventions will really make an impact on how American Indians view their health and how hypertension can greatly impact.
Starting off with community blood pressure screening booths. So basically during these screenings, we can actually check their blood pressure and also hand out educational material. There is a manual that I actually found out existed that is specifically for American Indians and Alaskans, which presents information about the cardiovascular system and risk factors in a way that is tailored toward their education or toward their understanding and cultural and traditional aspects, which is amazing. These handouts would teach this population how to take charge in their health in ways that fit their lifestyle and traditions, helping them prevent high blood pressure before they begin. For example, teaching them the DASH diet, but in a way that is fitting for them. Thanks to this knowledge that we know that is provided by this manual, they actually were able to see a massive increase in the understanding of what blood pressure is, because these handouts again provided what normal and abnormal readings were, again what blood pressure was, what were the risk factors, and also things that they can do to prevent them, and also what are some warning signs that would lead to them or will indicate like, hey, I need medical attention. Collaborating with tribal health programs. So working together with these tribal health councils and representatives, it's vital for us as medical professionals because it allows us to present information that can be overwhelming in a way that is digestible and easily understandable for them, and also makes them feel like they are taking charge of their own healthcare. Because if we just go in with modern medicine and try to present that to this tribal or this community, they will see it. They won't see it the way we see it. We see it as a way of we're trying to help, as they will see it as we're trying to control them, which is primarily one of the reasons why they still to this day keep their barriers up, because they don't want to be consumed by modern technology, modern medicine. But like I said, it's vital because they are able to present hypertension in a way that is digestible to them, but also present stuff that allows us to value their daily activities, value their daily traditions. So then health promotion incentives. So offering patients incentives such as blood pressure cuffs encourages them to continue monitoring their blood pressures at home. This encourages them to become more involved in managing their own health and allow for more frequent blood pressure checks, helping them identify hypertension early, which is good, so we can negate all the vascular damage that does happen. Before, like I said, before it progresses to to levels requiring medication. When detected early, simple diets and lifestyle modifications can offer corrective actions to these elevations.
Now that we have identified the need for hypertension education in the Lumbee Indian population for Robeson County, evaluated the literature to understand clinical implications and potential interventions, and identified potential strategies for impact, it is time to conduct an economic analysis for the proposed health fair intervention. An economic analysis helps to ensure that resources are being used most efficiently and effectively. We are proposing to conduct a health fair on a weekday to engage as many as possible, since most work during the week, and to avoid the impact of lost work. A trusted nurse from within the tribe will perform and record blood pressure readings on an index card. The event will be conducted in a common area identified by tribal leaders as a trusted place to gather with tables and chairs. All direct costs, including blood pressure monitors, index cards, and printed educational materials, will be donated by the federally funded Community Health Center. Adult tribal health ambassadors will lead a talking circle discussion about normal blood pressure, health risks stemming from high blood pressure, treatment options to reduce blood pressure, and services available for support aligning with the free educational materials published by the Indian Health Service. The nurse will then demonstrate proper use of the blood pressure cuff to allow participants to practice using their new monitor. Arietta et al. Estimated a net savings of $33 to $166 year one and $410 to $1,364 up to 10 years with use of a home blood pressure monitoring device. Per their estimates, the return on investment is as little as 85 cents per dollar invested year one and $19.34 at 10 years. They note, however, that returns vary by age and plan coverage. To ensure a favorable physical net benefit, a cooking demonstration will not be pursued and participation incentives will not be provided.
Community-based participatory research involves interprofessional relationships between the leadership of the tribe, tribal health ambassadors, nurses, doctors, and pharmacists, and is vital for community involvement. This allows for comprehensive data about health concerns within the tribe to be obtained. It also allows cultural identities and values within the American Indian community to be expressed and incorporates interventions and promotes a collaborative, trusting approach where members of the community want to participate. Community-based participatory research ensures the care is aligned with what the Native American community views as important and creates community-driven goals. The relationship between health professionals and tribal leaders creates a safe space for essential clinical knowledge to intertwine with cultural knowledge. This creates an overall comprehensive approach to the health of the community and promotes sustainability. Irby et al. Leveraged talking circles and youth tribal health ambassadors to promote culturally sensitive, strength-based, and sustainable engagement of North Carolina American Indians in health promoting conversations.
Considering our evaluation plan and expected outcomes, we used a program and policy analysis looking back at things that have been successful and things that have maybe failed in the past. Things that we found have been successful and are recommended are tribal involvement and community engagement. So we're trying to lean into utilizing members of the community and increasing the buy-in, hopefully, of our target population, and cultural acknowledgement and relevant education for this population is really important. And we are trying to specifically reach out with intention, utilizing that cultural competence that we hopefully are gaining through this research and planning this implementation project. What's failed in the past is overlooking the cultural influence and not involving those tribal voices, and inadequate funding, which hopefully with the low cost, high reward plan that we have, we can avoid some of these shortcomings. Programs that have been recently or currently are implemented relevant to this population and hypertension include the CDC travel practices for wellness in Indian country. This program supports practices that can promote cultural connectedness as a pathway to wellness and chronic disease prevention. The Indian Health Service Native Hearts Initiative is a comprehensive strategy that is designed to promote guideline-based diagnosis and management of coronary heart disease, heart failure, hypertension, and atrial fibrillation in this population. And lastly, iReach Native Chart through Washington State University is an acronym actually that stands for Native Controlling Hypertension and Risk Through Technology, and their goal is to improve control of blood pressure and other risk factors for cardiovascular disease in American Indians and similar populations. So looking at all of these populations and programs and pulling the successful components of each of them and avoiding the failures, hopefully our health fair is going to be a success. Goals for the health fair are to screen at least 100 community members and refer at least 50% of elevated blood pressures for follow-up within 30 days. We would also like to increase participants' knowledge of hypertension prevention strategies. And we're going to be collecting data through screening logs, blood pressure readings, and participant surveys, where we should get some qualitative feedback on the cultural relevance of the health fair education. We will be increasing blood pressure screenings and hypertension awareness, and doing that through a cultural competent lens, which will hopefully improve the trust in local healthcare workers. And we hope that these impacts will lead to early hypertension recognition, referral and management, and improved follow-up, and will also strengthen relationships between the community and primary healthcare providers. We are hoping to utilize this model for future regulatory we are hoping to use this model for future and regularly. We are hoping to evaluate how well this does and hopefully utilize the same implementation outline. We are hoping to utilize the same model for future, we are hoping if this shows success, we hope to utilize this health fair as a model for future health fairs, even within the same community, so that we can keep growing this impact and improve blood pressure control rates among American Indians in this specific population, and also reduce complications of hypertension long term. We have found that American Indians, particularly the Lumbee tribe, are disproportionately affected by hypertension, with various social determinants of health impacting their health outcomes. The proposed health fair would increase blood pressure screening, culturally tailored education, collaboration with tribal representatives, and health promotion efforts to address and improve hypertension. The cost-benefit analysis yields high reward for a low cost, and this intervention has the potential to overcome key barriers, including access, trust, education, and follow-up care informed by reviewing similar programs' successes and weaknesses. Evaluation will track participation and cultural relevance of the healthcare's effectiveness. We will be taking these thoughts with us as we care for future patients. We have increased understanding of the American Indian and Lumbee tribes' historical background, social determinants of health barriers to care, and mistrust of the traditional healthcare system. We've highlighted the need to understand the significance of providing culturally competent care intentionally and in innovative ways, with recognition of the link between the social determinants of health, illness, and culture. We've demonstrated the value of collaboration with community members and interdisciplinary professionals, and recognize the cultural adaptation needed to tailor health programs and disease prevention strategies to different populations.